share the link later with us.
Yes, I'll do that. So, greetings and a warm welcome to all the increased present here. I am Shwastika from Team Clearnit, serving as the allocated session assistant to ensure a seamless experience. Clearnit is India's most trusted and widely used digital platform offering a multitude of enriching services exclusively for doctors. Clearnet is elated to be chosen as a digital partner for this event organized by Indian Association of Preventive and Social Medicine. Let's begin today's session. The focus of today's session is health economics. So let's begin today's session for which I would like to invite Dr. Animesh sir. Over to you, sir.
Thank you, Swastika, and thank you, Clarnet. So here we are again with another edition of IAPP, which is a very important program, and it's a flagship program of IAPSM Karnataka State Chapter. We've been doing this for quite some time now. As you all know that this has been a place where we do webinars on some very contemporary topics and some very important topics, which is well attended by postgraduates and even some faculty members. And then this gets archived on the YouTube channel of Indian Association of Preventive and Social Medicine Karnataka chapter. So it becomes a very valuable resource. Before proceeding further, I would like to invite Dr. Poonam, who's the president of IAPSM Karnataka chapter, to have her opening remarks. Dr. Poonam, over to you.
Yeah, thank you, Dr. Animesh. Good evening, all. Good evening, Dr. Subhas Babu. Thank you
Good
for
evening, madam.
good evening, and thank you for accepting our invite to be the resource person. So,
Pleasure is mine, ma'am.
this
Thank you.
thank you, sir. So, the health economics topic, we all know that it is very important, especially for the postgraduates, both from theory point of view or exam point of view, and also when it comes to the practical application when they go into public health policy making. So it would be of critical importance for the postgraduates or budding public health professionals, and also for the other colleagues as well. So I'm sure, sir, this session of yours would be of significant importance and usefulness for everyone, sir. Thank you. Thank you,
Thank
Dr.
you, ma'am.
Anish.
Yeah. So thank you, Dr. Poonam. I'll just quickly check if Dr. Sunil is here. I don't see him, but I'll just check. If not, with Dr. Poonam, can we proceed further?
Yes, yes, please,
Okay.
please.
So welcome again, everybody, and we are going to have this talk and session on health economics, for which we have our resource person for today, Dr. Subhas Babu. Let me briefly introduce Dr. Subhas Babu. So Dr. Subhas Babu is currently an associate professor in the Mandya Institute of Medical Sciences. I've known him for some time. I've had the pleasure of listening to him, seeing his sessions, and interacting with him in various fora. And thank you, Dr. Subhash, for agreeing. Let me just tell you a little bit about his qualifications and how he is the apt person. So he completed his MBBS from WIMS Ballari in 2003 and then went on to do his MD in community medicine from BMC, that is Bangalore Medical College and Research Institute in Bangalore. And he has never stopped learning. That's what I can make out from what I have his CV. So he followed up by doing an MA in economics, and that was in 2012. Following that, he also went on to do a DNB in preventive and social medicine. And very recently in 2022, he's completed MA in population studies from the International Institute of Population Sciences in Mumbai. And just a little deviation, he has also been interested in knowing about medical law and ethics, and he's invested time and energy into that. And he's done from a very prestigious institute, that is National Law School of India University, PG Diploma in Medical Law and Ethics, which he qualified in February 2011. Briefly to tell you about the work experience that he brings in. So he's been a nodal officer for Revised National Tuberculosis Control Program, or RNTCP, core committee, and then he's also had additional responsibility of resident medical officer of Mandya Institute of Medical Sciences Hospital from July 2014 to November 2015. Other than that, he's also had been the opportunity to be a program officer for NSS and also the regional manager in Karnataka Health Promotion Trust, which we know as KHPT, for about a year. And other than that, he's also been active in multiple projects. He's published extensively, and he's also been involved in multiple academic as well as responsibilities outside the institution. He has delivered lots of lectures and talks and CMEs. Very interestingly, I see there is a person who's been trained in medical education at very prestigious institutes. Why do I say that? Is because he's done the very commendable and I would say that any medical educator would vouch for is the NTTC, that is National Teacher Training Course in Puducherry, that is Jipmer Puducherry. And he's also been trained in St. John's in Bangalore in basic MET, revised basic MET, and competency-based medical education. So we have a person who's well accomplished, who's done his MA in economics, and also a very valuable member of the Faculty of Community Medicine at MIMS Mandya. So with that, welcome you, Dr. Subhas, and over to you.
Thank you, sir. Thanks for that nice introduction and kind words. I take this opportunity to thank IAPSM Karnataka chapter for giving me this opportunity to talk to doctors and young professionals in community medicine and public health. I hope this session will meet their expectations. With your permission, can I start, sir and madam?
Yes, please.
Please go ahead. Please go ahead.
Yeah.
Yes, sir, please.
So I hope I'm visible to you and my voice is audible to you all, and
Yes,
also
absolutely.
the slides are visible.
Absolutely clear voice, and the slides are visible. Please go ahead.
Yeah, thank you. So I would like to begin. As already you all know that I'm working as a faculty in community medicine. So this interest in economics, it initially started when I was preparing for my UPSC. I couldn't clear that, but I got into mains, but I couldn't clear the mains part. That was an added opportunity to learn about economics, how actually we work in the real world. So humans have created a world which is basically revolving around money. So with that words, I would like to begin.
Anything, Dr. Babu, that we can help you with? It's come. The next slide has come.
No, I mean it was a little slow.
Okay. It's changed.
And
now.
Also, as I'm using my headphones, I'm hearing my own words.
Okay.
Okay. So in 2009, there was an article published in the Hindu. Basically, it was an editorial which was written by Dr. Srinath Reddy sir, who is a cardiologist and also an MPH degree holder. So he is the founding president for Indian Public Health Association, Indian Institute of Public Health. So in his article, he wrote that there were a few missing E's in medical education, which has been addressed, which is being addressed through the NMC guidelines now. So the missing E's in his articles were epidemiology, economics, ethics, empathy, and engagement. So ethics is being addressed by the ADCOM module that we see right now in NMC guidelines, NMC curriculum. So we will be talking about economics now. So the goal of the session is not to provide an exhaustive aspect of economics in health or health economics is about. So it just I'll be providing an overview of health economics, or what is bird's eye view, and what health economics basically addresses. Now there are I just framed a few specific learning objectives for this session. So the first one would be familiarize your audience with and understand the definition of economics and health economics. Learn about basic concepts of economics used to study health and healthcare problems. Understand the role of economic analysis through a case study, and direct the learners or audience to resources on health economics. So with these objectives, we will just move on to certain questions which have been asked in PG examinations of the University of Rajiv Gandhi University of Health Sciences. So I just want you to just go through these questions and think in your mind, how would you be answering these questions? Discuss in detail about health insurance in India. Discuss the delivery system for the National Family Welfare Program at various levels in India with critical appraisal. So these are questions which I've taken from the previous year's question papers. So I just want you people to think over these questions. How would you be answering these questions prior to attending this session? So again, these are all questions taken from the PG questions. One was from the Rajiv Gandhi University of Health Sciences question bank, and also SRM University, Sri Ramchandra Mission Medical College. Okay, so quite a few questions. So this person he won his Nobel Prize in Economics, which is called as the Sveriges Riksbank Prize in Economics in the memorial of Sir Alfred Nobel. So he defines economics as the study of societies, of how societies use scarce resources to produce commodities and distribute them for consumption now or in the future among different groups. So this definition is termed as equity-oriented definition or growth-oriented definition. So for his work in economics, he received the Nobel Prize in economics in 1970. So the first economics prize was started to be given in the year 1969. Uh, so then we come on to the other definition by Lionel Robbins, who was a UK economist. Uh, Paul Samuelson was from US and Lionel Robbins is from UK. So his definition is known as the scarcity definition, which mentions that economics is a science which studies economic problems arising out of unlimited wants and limited resources. So this definition is famously known as the scarcity definition. So we have two definitions. One is the equity-oriented definition or growth-oriented definition, and scarcity definition. So what these definitions involve is human behavior. So human behavior, what determines how we use resources. So economics is concerned with how people make choices in the face of scarcity, and we make these choices to uh, achieve certain ends. Like these ends refer to various goals, desires, or wants that people seek to satisfy. And every time there are scarce means, that is means in the sense resources. So resources are always scarce, which includes time, money, and natural resources. So the scarcity definition implies that they are limited in relation to the potential demand for them, and there are always alternative uses for these resources. So for example, if we have 100 rupees, we can buy anything from that. I mean, in the sense, what you can buy from 100 rupees, there are alternative uses for that use money. So alternative uses implies that resources can be used in different ways to satisfy various ends, requiring choices to be made. So now what is health economics? So the definition of health economics is the application of economic theory, models, and empirical techniques to the analysis of decision making by individuals, healthcare providers, and the government with respect to health and healthcare. So this is the definition of health economics. It's the application of economic theory, models, and empirical techniques to the analysis of decision making by individuals, healthcare providers, and government with respect to health and healthcare. Now, why are we so concerned about health economics? So if you look at healthcare spending in different countries, mainly our country and the biggest country which invests in health, the healthcare sector of the economy is very large. So for the financial year 2022, India incurred around 9.4 trillion rupees as health expenditure, including government spending, out-of-pocket expenditure, so which accounted for 3.8% of our GDP, of our India's GDP. Whereas if we look at USA in 2023, the health expenditure was $4.9 trillion, so which accounted for 17.6% of GDP. So which included Medicare, Medicaid, private health insurance, and out-of-pocket expenditure. So Medicare both are social security measures, but Medicare is for elderly population Medicaid is for people who have any kind of disabilities and people from lower socioeconomic strata. So both are provided through government in USA. Now, with the definition, it implies that we need to learn that the resources are being used to procure some goods. So now, what is an economic good? Any good or service that is scarce related to our wants for it. So that is known as an economic good. Now, with this definition, it is implied that healthcare is an economic good, and also health per se is an economic good. Providing healthcare involves costs, it satisfies needs, wants, desires of people, but at the same time, resources are limited. Now, before we go in depth about health economics in this introduction, we need to be familiar with certain concepts of economics, like utility. So, now what is utility? It is want satisfying power. So, for example, we want to go get ourselves tested for whether we have any diabetes mellitus or hypertension. So, just having the desire will not be enough. So, we need to go to a diagnostic center, go to a doctor, and then get ourselves tested. So, that is our want. So, utility is want satisfying power. So, anything which satisfies a human want, directly or indirectly, is said to possess utility. So, clinics, diagnostic centers, they possess utility. Now, what is total utility? Total utility is the total satisfaction which a person derives by consuming all the units of commodity. Say, for example, if you are eating in a buffet. So, if they have varied amount of, different kinds of sweets, we might get satisfaction by consuming different kinds. I mean, if you like eating sweets, we might. Sorry. I'm listening from a headphone. I'm listening my own words. So, if you are interested in consuming sweets, we might derive satisfaction by consuming all the different types of sweets. So, that is total utility. So next is marginal utility. So, marginal utility is the additional utility derived from consuming the last unit or additional unit of good. Say, for example, I'm very fond of eating sweets like jamun. So, but I may not be able to eat hundreds of jamuns. So, the utility of eating jamun or any particular kind of sweet might go on decreasing. So, at probably my capacity is to eat 10 jamuns. So, when I eat the 10th jamun, I'll be very satisfied. I may not be able to move forward. So, that is the marginal utility. So next is economic analysis. So most of the large scale programs, healthcare programs, it involves a lot of economic analysis to be made. So there are two kinds of economic analysis. One is microeconomic analysis, and the other one is macroeconomic analysis. Now, what is microeconomic analysis? It is partial analysis of economic problems. Like it deals with problems pertaining to households, business units, and individual markets. So basically, how households procure consumables, from where do they mobilize money, and how they spend that money. So explains how prices of a commodity, its production, its consumption, etc. are determined. So this is the realm of microeconomic analysis. So the same way, if we apply that to healthcare sector, microeconomic analysis involves costs involved in running a subcenter, a clinic, or a pharmacy. So next is macroeconomic analysis.
Sir,
So
one second, sir.
macroeconomic.
Sir, could you hear me? Yeah. So may I request the participants to kindly maintain appropriate decorum and decency when they are switching on the video. If not, they can switch off the video. This is not mandatory to keep the video on. I also request Swastika from Clarnet to kindly monitor this. Please understand that this is a forum which is going to be even recorded. I think some decency we can be expecting. Thank you. Sorry, sir, for the interruption.
Okay, so next is macroeconomic analysis. It refers to aggregative analysis of economic problems. It studies economic problems as a whole. So it deals with problems pertaining to industries as a whole, population, aggregate volume of output, and national income of an economy. Like, for example, costs involved in providing primary education in India, production costs of a new vaccine or drug, or budgetary allocation for health at different levels, like center, state, and districts. So this is the realm of macroeconomic analysis. So both micro and macroeconomic analysis are interdependent, and every microeconomic problem involves macroeconomic analysis. Similarly, every macroeconomic analysis requires microanalysis. So we have gone through various terms like utility economic analysis, micro and macroeconomic analysis, uh, total utility, marginal utility, and economic analysis. So now coming to health economics, the work of this person, Kenneth Arrow or Kenneth Joseph Arrow, is of tremendous importance. So in 1963, his seminal work in 1963 that he propounded, he tried to equate health as an economic good or healthcare as an economic good, but with certain differences. Now, what is the important aspect in healthcare or health or medical care is uncertainty. So we never know when we will fall ill. Okay, so the chance that an individual will fall ill during his lifetime is certain, but we don't know when it is going to happen. So that is the important aspect in health economics. And also, demand for healthcare is random and unpredictable. Again, recovery from disease is also as uncertain as its incidence. Say, for example, if you are going to treat an individual with MI, myocardial infarction, we never can predict how he is going to respond, how he is going to recover. So, disease is also uncertain, and recovery is also uncertain. And all patients do not behave the same, and patients do not behave like consumers, like consumer of a particular good. Say, for example, if you want to buy a car, you can check the car. Okay, but if you want to procure healthcare, there is no way in which you can check it. Okay, in the sense, if you have myocardial infarction and get treated for that, there is no way in which you can test a particular doctor before actually going for that. Okay, so though we can get the feedback from different people, it is a one-time chance, one-time event. And again, doctors also do not behave the same way as other firms. In the sense, in medical care, we follow certain ethical principles. We follow professionalism, and there is no advertisements, unlike other goods. So those are the separating factors or unique factors Kenneth Arrow identified when delineating healthcare from other economic goods. Now, coming to demand and supply. So any economic function, it depends on demand and supply. Now, what is demand? It means how much an individual will be willing to buy commodities at a certain price. Say, for example, you want to buy vegetables from a market. We will not buy in a lot of in quintals, or we only buy vegetables as much as necessity. So demand is how much we buy, how much we are willing to buy at a certain price. So demand is the amount of commodity for which the consumer has not only willingness to buy but also ability to buy.
Have I lost you? Okay. Because I can't
Hello.
hear you. I can't. Now, yes.
Hello.
Yeah.
Yeah. So I was talking about demand and supply. So demand is the amount of commodity for which the consumer has not only willingness to buy but also ability to buy. So if you just remember, during the pandemic, the N95 masks were very costly. So we were not buying as much as was needed or required. So we would always weigh our buying ability. But now it has become a norm and it is more available. So next is supply. Supply means amount offered for sale at various prices during any period of time. And supply gives relation between the price and the amount supplied for sale. When price rises, supply also increases. When price falls, supply also falls. So if you just equate it with many other commodities in the market, when there is more gains from that particular commodity, people try to supply more. But in the subsequent slides, you may ask a few questions which will be addressed later. So next is real cost. So real cost is a subjective concept. It also involves efforts and sacrifice of the factors or its owner. So that is the real cost. So it does not include so it does not include the efforts and the sacrifice that go into producing it. So the money paid for securing the factors of production is the money cost. So a very important concept in health economics and other branches of economics also is opportunity cost, which is also known as alternate cost. So what does it mean? It is the cost of committing resources to produce a good or service. It is the benefits foregone from those same resources not being used in the next best alternative. Okay, so that is opportunity cost. So to give a few examples, so if we invest in specialized hospitals, I already please remember the scarcity definition. It means the achieve. I mean, with the potential uses of those. Hello. Yeah. So if you are investing in specialized hospitals, if there is a particular allocation of resource, either you can invest in specialized hospitals or you can invest in primary healthcare. If you are going to invest in specialized hospitals, we won't be able to invest in primary healthcare. So the opportunity cost is the investment that we are, doing away with investing in primary healthcare. So the similar example is focusing on high cost interventions versus preventive care, importing medical equipment versus promoting local manufacturing. So these are opportunity cost. If you are investing in one aspect, you will have to forego investment in another aspect. So that is what opportunity cost is about. Another important function in economic production is labor. So we have different kind of personnel, healthcare personnel who are contributing to health and healthcare. So now labor includes skilled and unskilled workers, artisan, and all those employed in education, science, administration, and fine arts. So it so happens many times that we don't consider ourselves as labor, doctors, I mean professions, people in professions. But to make it very clear, people right from the administrative sector, from the topmost administrative sector, to the person who's in the lowest rung of the economic strata, we are all providing labor. Okay, so now characteristics of this labor is labor cannot be separated from the laborer. Labor is perishable. Say, for example, a person who is cleaning the floor or mopping the floor, the floor is bound to get dirty. So they need to continue working. So labor is perishable. Labor must be undertaken for a reward. Labor involves strain and sacrifice. Labor must result in the creation of wealth. So that is a concept of labor in economics. So as you can see, there are different cadres of healthcare workers who are working in healthcare sector, be it in the hospital or in the field. Now coming to certain mathematical terms that are of importance in economics. They're quite simple. So ceteris paribus, that provided every other factor is same, the quantity demanded of a commodity is inversely related with its prices. So lesser the price, more the demand. But there is a limit. Okay, so we can represent this statement in this equation where QD is equal to quantity demanded. So this here in this equation, QD quantity demand is equal to 30 minus 5P. 30 is a constant. Okay, so when price is phi is a constant. If the price is zero, 30 units will be demanded. Okay, So when the price is 2 or 3, 3, I mean, if it increases, the quantity demanded will come down. You might be wondering, I mean, for example, you might be thinking that if it is 6, if the price is 6, then the quantity demanded is 0. So, but it is not as simple as that. So let's assume as of now that there is a limit for that. Okay. Okay. So this is a simple equation where you can I mean, you can derive an equation where there is a quantity demanded for a particular price. So this kind of equations, it tells us of the relationship between various economic variables, how it can be written in the form of functions. So where quantity demanded is a function of price, where in QD is equal to F of P, quantity demanded is a function of price. C is equal to F of Y, consumption is a function of income. Say where Y is income, C is consumption. It is a logical assumption where people with high incomes, consumption is more. Okay, so it is in simple terminologies. So moving on to another simple mathematical equation. So these are called linear and I'm sorry. So linear functions or linear equations. So you can term these linear equations in simple formula like ax plus by plus c is equal to 0. If x and y are two variables and a, b, and c are constants, the function is said to be linear. So another linear equation is y is equal to mx plus c, where y is the dependent variable and x is the independent variable and c is a constant. So if we just take this equation, let's say a clinic has a fixed cost of $1,000. So it requires that kind of investment. And each vaccine administered costs $10. The linear equation representing the total cost based on the number of vaccines administered would be y is equal to 10x plus 1000. So y-axis represents the total cost in dollars. So y-axis represents the total cost, and x-axis represents the number of vaccines administered. So slope m is equal to 10. So for each additional vaccine administered, the total cost increases by $10. So what we need to keep in mind is, even if no vaccines are administered, the clinic still incurs a cost of $1,000. Okay, so this is an example for linear function. But in economics, it is not always that it takes a linear or a straight line. So here they're called non-linear functions. So the lines are curvilinear. Okay, so this is an example where we are comparing the demand for petrol or liquefied petrol, LPG or diesel, compared to its price. So this is a curvilinear or a non-linear demand curve. So in health economics, a non-linear function example could be the relationship between healthcare spending and health outcomes. Hello? Through health. Say for example, vaccinations or usage of antibiotics for infections. But if the individual were to go into SIDS, like or severe acute respiratory syndrome, the investment goes on increasing. So, but after a certain point, further spending may yield diminishing returns. So, resulting in a curved rather than a straight line. So, so this kind of relationship is called a non-linear relationship. So, this is because the most impactful interventions are implemented first, and subsequent spending might be directed towards more complex or less effective treatments. So I hope that you will be able to draw comparisons in healthcare sectors. Say if an individual is give an example, if an individual is admitted with pneumonia, so initially low cost interventions would be treating with antibiotics. But if the individual develops complications due to pneumonia, if he develops respiratory failure, the interventions and the cost of interventions goes on increasing. Now, next we move on to what is called as production function. So, production function is a technological relationship between inputs and outputs. So, the inputs are the same in most of the economic production. So, it involves land, labor involving various kinds of healthcare personnel and ancillary personnel, support staff, capital, initial money that is required, raw materials. So those are the inputs. Now, what are the kinds of outputs that we're looking at? It is provision of clinical services, might be outpatient department, inpatient departments, diagnostics, and also involving low yield. Many times we think that doing these things are a necessity and it doesn't involve costs like autopsy, ambulance services, or even organ retrieval services. So all these things involve costs. So the production function is going to find out the relationship between the input cost and the output cost. Now, how can we write this in a equation? The production function explains the functional relationship between physical inputs and physical outputs of a firm. It can be written as Q is equal to function of A, comma B, comma C, comma D up to N. So where Q is equal to rate of output of a given commodity, and A, B, C, D are different factors and series used per unit of time. So it shows the maximum rates of output that can be obtained from different combinations of the productive factors during a given period of time or unit of time. Say, for example, this is a production function table. Okay, so here on the x-axis we have input of labor, and on the y-axis we have input of capital. Say, for example, for 3 units of
Requesting
labor
attendees,
and 3 units of
attendees to
capital. Hello?
kindly mute themselves. Requesting attendees to kind interruption. I can hear people talking at the background. Requesting attendees to kindly mute themselves. Otherwise, you may leave the meeting, but please do not disturb others. Swastika, may I request you to kindly see to it that you mute people, and otherwise you can remove them from the meeting. Kindly give me the control. Make me a call.
Hello?
Please continue. Please continue. Unfortunately, we have doctors who are like not able to understand things about decorum, about being mute in the meetings.
Can I continue, sir?
Yes, please.
Yeah.
And
so this is a production function table which mentions the output per unit of time. Say, for example, if we have 3 units of labor and 3 units of capital, so the output will be like 846. I mean, this is a number. This is an imaginary number. So you can just think like if there are 3 nurses who are posted in different shifts or in the same shifts in a ward, the output may be in terms of looking after 10 patients in a ward maximum, without actually causing a lot of strain on the healthcare personnel also. So again, sometimes it may be reduced to 2, it may be increased to 4. So we need to find out the production function. So what would be the optimum production function of labor and capital? So that is what production function table is about. Okay, so now we move on to examples, real world examples. So I would like to bring your attention to this article where they used economic analysis to find out what would be the impact of novel tuberculosis vaccine on economic growth in low and middle income countries. So they did a modeling study. So what did the researchers do and what did they find out? So they estimated the impact of introducing novel TB vaccines on gross domestic product growth in around 105 low and middle income countries. So they used a macroeconomic model to simulate country level GDP trends between 2020 and 2080 in 2020 US dollars. So they compared scenarios for introduction of infant and adult vaccine candidates to a no new vaccine counterfactual. So in the sense, what would happen if they introduce an infant and adolescent vaccine compared to having a no new vaccine? So what did they find out was, compared to the no new vaccine counterfactual, in the sense we already have a BCG vaccine. So if you are not introducing a new vaccine, both vaccination scenarios produced greater cumulative GDP in the model countries over the study period, that is from 2020 to 2080, equivalent to around $1.6 trillion in case of adolescent or adult vaccine, and around 0.2 trillion for the infant vaccine. So, as per the study, introducing an adolescent or adult vaccine is comparatively high yielding compared to introducing a infant vaccine compared to what exists now. But nevertheless, it is more uh, economically productive compared to the no new vaccine counterfactual. So these GDP gains were substantially lagged relative to the time of vaccine introduction and concentrated in countries with higher current TB incidence, that is low and middle income countries. Okay, so one thing that we need to keep in mind is, if you're not going to do that even on a small scale, we will not be able to prove that it is going to be effective and efficient, economical. So I was mentioning about the case study. So how we'll understand how economic analysis helps us by going through a case study. So these are the Nobel laureates in 2019, Abhijit Banerjee and Esther Duflo. They are couples. So they got the 2019 economics Nobel. An interesting aspect of their finding is that they used randomized control trials, what we routinely or what we think routinely do in our epidemiological studies. So they used randomized control trials and mostly field trials. Okay, so most of their trials were done in the field, in communities. So along with Michael Kramer in 2019, they received the Nobel Prize for their experimental approach to alleviating global poverty. So you would be surprised to know that many of our public health program interventions have benefited from their study. Okay, so taking one example, they did studies in Bangladesh, India, and also Michael Kramer did it in Kenya. So in a few settings, in few community settings, the vaccination coverage was poor. So they wanted to find out how to improve the vaccination coverage. But we couldn't select, they couldn't be biased in selecting these villages. Okay, so the control group, we already know that vaccination programs are running in the field. So in the control group, uh, the vaccination program continued as such. Like, people had to go to a fixed center where vaccination would happen, and there was another arm, a trial arm, where mobile clinics were introduced, and another part of the trial arm was, along with vaccination, mobile clinics. The children were, or the attendants were given a supplementary nutrition like lentils. So what they found out from the experiment was, it is obvious. What is not obvious is how much would it improve vaccination coverage and how much would it reduce the vaccination cost. So that is what they found out. Okay, we all know that providing supplementary nutrition aids in vaccination coverage, or providing mobile clinics aids vaccination coverage. But the question is, in economics, how much is it going to improve, and at what cost is it going to improve? Okay, so in the control group, they found out that it remained at 6%. The vaccination coverage remained as such. In mobile clinics, it went up by 3 times compared to control groups. So it increased by 18%. It went up by 18%. So the cost incurred was $56 per vaccination. Whereas in the mobile clinic with incentives, it increased by 39%. So that the cost incurred was $28 per vaccination. So what I found out was, the mobile clinics, it increased vaccination coverage, but the cost incurred was around $56 per vaccination, because the mobile clinic itself required investment. So even if you don't cover or administer vaccines, it incurs a capital cost. Whereas mobile clinics with incentives, it increased the vaccination coverage to 39%. Compared to control group, it almost went up by 6 times. But also at the same time, the vaccination cost was less than, I mean, half of only mobile clinics. So providing an incentive along with mobile clinics worked very well. Now, it comes as, I mean, it brings us to a very fundamental question. Though it improved the vaccination coverage by 39%, there were 61% of children were still remained partially immunized. So it tells us that people are not always rational. There are other factors which go into play when they seek healthcare. Okay, though it is a necessity. This is explained by what is called as present bias. So our present takes up a great deal of people's awareness. In the sense, if you want to buy health insurance, you're going to compare it with our present scenario. So we will always postpone it. So we will take it tomorrow or we'll take it in the next year. So that is what is called as present bias. So now governments are introducing what is called as temporary subsidies. So by these studies, what they found out was giving temporary subsidies, it is better than giving permanent ones. So when they are giving temporary subsidies, it reduces incentives to delay investment. So people start thinking whether it is going to be there tomorrow or not. So they're going to invest more. So that is what we are seeing now in our Shakti Yojana, also in Karnataka Shakti Yojana, where people are traveling more because they know that it is going to be temporary. So they're going to utilize the services better. And this kind of work has influenced policy decisions also. To give a few examples, uh, albendazole, usage of albendazole, a free distribution of albendazole is an outcome of this study. Basically, what they found out was when albendazole was given free, 75% of the people would ensure that children would take the albendazole. Whereas if the even if it is subsidized, if the albendazole cost was, I mean, it was given at a rate of less than $1, the coverage actually came down to 18%. So what we need to realize that in low and middle income countries, people are very price sensitive for preventive healthcare, like vaccination or prophylactic drugs. Okay, so it works especially if it is given freely many times. Okay, so these kinds of interventions are actually attributable to the work done by Michael Kramer, Abhijit Banerjee, and Esther Duflo. So economists like them. So with this case study, I think I may have been able to achieve the objectives that I initially set out with. So again, we'll go back to those objectives. So I went through the definitions. I hope you are familiar with the definitions and you have been able to understand the definition of economics, especially the scarcity definition and equity definition. So we went through the basic concepts of economics, which are used to study health and healthcare problems. And what is the role of economic analysis through case study? And I'll be directing you to resources on health economics. And now coming back to those questions, with the presentation, are you able to answer these questions in a different way now? So my whole objective, I mean, the goal was to bring in an economic perspective to answer these questions. So now if you're going to answer these questions, I hope you will be able to answer them in a different way or more comprehensive way or a more economic perspective. So I would like to acknowledge the Department of Community Medicine, Mandya Institute of Medical Sciences, Mandya. Again, Indian Association for Preventive and Social Medicine, Karnataka chapter. I thank Dr. Animesh sir for having moderated this session, Dr. Poonam madam, and also Dr. Asha for having approached me for to deliver this lecture. I thank all the participants who have been patiently listening. Thank you all. Again, lastly, the resources and references. These are my references. The newspaper article. I also use the MPP module for MA Economics from Karnataka State Open University. A very important textbook, by Stephen Morris, Nancy Devlin, and David Parkin. Economic Analysis in Healthcare. The article, The Potential Impact of Novel Tuberculosis Vaccine Introduction on Economic Growth in Low and Middle Income Countries. If you want to learn more, if you visit Swayam portal of Government of India, there are courses like Economics of Health and Education, Economics of Health and Healthcare, and also the World Bank has a free course on Basics of Health Economics, which is a self-paced course. And the World Health Organization, it uses something called EPIC, Economic Projections of Illness and Cost. It is not freely available as of now. You have to email them. So you just Google EPIC WHO, you will be able to go access this resource. So thank you all for patient listening.
Thank you, Dr. Subhash. Am I audible?
Yes, sir.
Yes, sir.
Yes. Yeah. If any questions are there, audience may put it on the chat, or you can ask him directly by unmuting yourself.
Also, I am going through these chats. I mean, for significant amount of time, I was not audible, I suppose. If it is available on YouTube, probably it will be, I mean, they will be able to access again.
It will be available on YouTube.
Okay, sir.
But the recording will be the same, this thing. Yeah. So they'll be able to see whatever has been recorded. I think
Okay, sir.
most of the part of the thing was fine. Anyone has a question can ask. I'm having some issue with Zoom. I got disconnected twice in between. I've joined, but again, it seems to be having some issue. Just in case I get disconnected, Dr. Subhash, you handle, and I think I'll ask Dr. Asha to do that as well if she's around.
Dr. Subhas, I really appreciate your effort. Really,
I hear Dr. Shashi's voice.
Yeah.
Yes.
Yeah, I'm retired from KMC Manipal and working for Srinivas at present. And so I really appreciate you put it so simple. Each time I go through, I find that, somewhere in between I stop. I even had way back in 2010, I had attended a session I attended a 3-day workshop. But,
Okay, ma'am.
But you made it so simple. I really appreciate that. You
Thank
brought
you
it
so much, ma'am.
to our level. So that's so wonderful. And I happen to hear from the you mentioned about cardiac MI.
Srinath Reddy, sir.
Haha. Yeah, I did not know what you told before that. Because now we have troponin. If we could get a level of troponin at zero or whatever level they come, and then we follow it up, and like if it is, I don't know in what context you mentioned, because troponin, I don't know the cost now, but will it not help, particularly in these heart attacks which are happening so often among the youngsters?
Okay, ma'am.
If
Ma'am,
that
I
can be
don't remember mentioning troponin, but
no, you didn't mention about troponin, but you mentioned about cardiac event.
MI.
Yeah, cardiac, any acute cardiac event. So if troponin can be used to identify,
Okay.
it can reduce the cost in ICU particularly. I was in the emergency room undergoing this troponin for one. I don't want
Yes,
to
ma'am.
further
Actually,
go
in
about.
our community medicine, in preventive medicine, there is a saying, no survey without service.
Yeah.
If you were to screen them for troponin, if you identify it, if we have the necessity wherewithal to manage MI, probably we'll be able to help.
Yeah,
But
not
if you're
in the
going to refer
community.
them, probably we're going to do it with ECG, echo, probably. I mean, even that is justified. Troponin is a lab investigation, and if it is made available on a large scale, provided the demand is more, the government may think so. So, but it all comes down to demand. Demand supply again,
Unfortunately,
it may reduce the price also.
yeah. I'm sorry to interrupt, but unfortunately, the government open, or any government for that matter, opens its eyes much later than when it should be. Precious young lives are lost. And today I heard
Yes,
about
ma'am.
another motivational speaker, this and that, and he ultimately died while delivering a lecture on fitness
Yeah.
or whatever. That's so
Yes, ma'am.
unfortunate. So we can't afford to lose lives like that. I told you I had a personal this thing. They were openly discussing in front of within my hearing, and they were
Okay.
doubting whether this is that, and I had to argue with them that I'm not having MI, and the
Okay.
troponin didn't raise that much. It was an acute
Okay.
cardiac event because of adrenaline intramuscular, which was
Okay, ma'am.
given for anaphylactic reaction on Jan 16th and 17th, I suppose.
Okay.
So yeah, I'm survived. I survived that event.
Okay.
I'm still going strong. So
That's
that
nice, ma'am.
dopamine helped there. So it prevented me from getting into ICU and getting mad at all the people there,
Okay.
because
Okay.
I knew that it was not properly managed.
Okay. So you're telling that
I was
because
not
it
properly
was
managed.
not elevated, it saved you from getting admitted to ICU. Yeah.
Huh.
In that way, it
Yeah,
is beneficial. Yeah.
so because that's a protocol for the emergency medicine people, so they did it.
I'm
So if
sorry to
this is
interrupt,
done,
but we'll
Okay,
we'll
ma'am.
get back to the health
Okay.
economics. We'll get
Yeah.
back to health
One
economics, please.
question that
This
is asked
yeah,
by
discussion.
that
Dr.
same thing.
Archana
Yeah.
on cost-effective analysis, cost minimalization, cost utility analysis. Okay, cost-effective analysis is yeah. In healthcare, we are not looking at efficiency only, because in economics we are looking at efficiency. Efficiency in the sense, if you're investing something, you should get the maximum possible benefit from it. That is efficiency. But in healthcare, we are more focused on effectiveness, because if it is not effective, even if it is efficient, it doesn't serve its purpose. So it has to be effective. So it may come at a larger cost, it may come at a higher cost. So effectiveness interventions need to be effective before they are efficient. Okay, so that is cost effective analysis. Like for example, uh, uh, okay, so the vaccinations, we know that they're effective to a significantly large extent. So the kind of investment that goes into administering different vaccines, so that is cost effective analysis. Now if you have to look at efficiency, now utilizing a few healthcare personnel, to what extent are we able to cover the vaccination schedules in our PHCs and sub centers? That would be an efficient cost efficiency analysis, cost efficiency. Now to do a cost minimalization, we need to do a costing in the sense, what would be the cost of each unit of the production function. Say for example, number of people involved in delivering healthcare, number of vaccines administered, number of syringes used, swabs. So each of these inputs will be costed. So then only we'll be able to do a minimalization, we'll be able to look at how to minimize that cost. Now, cost utility analysis, even I'm not very sure. Utility is, I already told you, utility is the demand satisfying function. So to what extent our demands are satisfied, so it is utility. That is more of a subjective analysis, cost utility analysis. So at the end, what it comes down to is compassion cannot be costed. So you cannot measure how much compassion can value. So that is the most important aspect in healthcare. Okay, so I hope cost effective analysis, cost minimalization, a few aspects I have been able to clear.
Thank you. So the person who asked question, Dr. Archana, has also thanked you.
Yeah, thank you, sir.
So if there are no further questions, can we close this? So thank you, Dr.
Okay, sir.
Subhash, on behalf of
Sir,
IAPSM. Yes, please.
sorry, sir. Sorry to interrupt. Madam was asking contact details. My email is p.subhash.babu@gmail.com or psubhashbabu@yahoo.com.
Okay, thank you, sir.
Yes, ma'am.
So, Dr. Subhash, thank you so much. On behalf of
Yeah.
IAPSM Karnataka State Chapter, I thank you for
Thank you, sir.
taking
Pleasure is
time
mine,
out.
sir.
Yeah, and enlightening us about health economics. I'm sure that this has benefited. As already informed, this will be put up. The recording will be put up on the YouTube channel of Karnataka chapter of IAPSM. That will happen in short time, maybe 3-4 days. So we will do that, and then please visit IAPSM Karnataka chapter YouTube channel for previous webinar recordings. They are very useful. They will definitely be helpful for you, especially the PGs. Right. So with that, thank you everyone for joining us, and we hope to see you again in future. I hand over back to Clarnet. Swastika,
Yes,
please
sir.
take it forward. Thank you.
So, and thank you so much to all the interviews present here. Clarence is really glad to have all these brilliant people together in the session today. And thank you so much for extending us the opportunity to host our session. And I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so
Yeah, I
much.
forgot, madam. Thank you also. Thank you, Clarinet. Thank you.
Thank you.
Thank you.
Thank you.
Good night.